We'll take a look at some of the axes, and first of all we'll start out with a slide called normal axis. This might be a good time also just to discuss what a typical 12 lead looks like. On the left side you'll see leads 1, 2, 3, AVR, AVL, and AVF. These are also known as the limb leads. And on the right side, V1, V2, V3, V4, V5, and V6 are called the precordial leads. If you haven't had the chance as a student to observe someone hooking up a 12-lead ECG, it would be very well worth your while, because you'll see, for instance, that V1 and V2 are hooked up on the right side of the heart on the thorax, and that V5 and V6 are on the left side. And finally, most 12 leads will have on the bottom a rhythm strip. This is oftentimes lead 2, and this is selected because it gives the best P wave morphology and QRS morphology. In the intensive care unit, they do sometimes use some modified leads, but on 12 leads it's often lead 2. So that's our typical 12 lead and what it looks like. And then as far as axis, again looking at the guidelines, it's fairly straightforward. We take a look at axis here, looking at leads 1 and AVF, and mainly the QRS axis is usually positive or negative, and some students ask, well, how do we know if it's close? In other words, if there's almost an equal amount of it above and below the line. Usually what I recommend doing is taking a ruler and measuring the line between the T wave and the P wave. That flat line is where I put my ruler and draw a line through, and then I count the small boxes above and the small boxes below on the QRS. And for instance, if it's 4 above and 3 below, that would still be a net positive axis. So lead 1 is upward and AVF is upward, so this is fairly straightforward. This would be a normal axis. Looking at the next slide, which is left axis deviation, we'll take a look at lead 1, and here it's upright, and if we look at AVF, it's down. But for left axis deviation, you have to look at one more lead. This is the only time you need to do that, and that's lead 2, which also must be negative. If it's positive in lead 2, this is often in the 0 to minus 30 range, which most cardiologists still feel is normal. And again, remembering when you see this that this is a tip-off that there's something else wrong with the 12 lead. And another axis example is the right axis deviation. And if we look at lead 1, that's clearly down, and AVF is up. So this would be examples of right axis deviation. And in addition to memorizing this, I would encourage the students also to look at the left axis differential and the right axis differential every time that they run into an abnormal axis.
The next section is on hypertrophy criteria for the 4 chambers of the heart. Dean, this looks pretty busy. Any helpful hints on these criteria?
It is busy, and although it will require using the guidelines, often the students will carry it in their pocket for the 3rd and maybe even some of the 4th year, it does finally become fairly easy to follow and can be done fairly quickly. One hint is whenever you're given a choice, such as an S wave in V1 or V2, or an R wave in V5 or V6, always pick the largest wave. Also notice the very small word or. When it says you can pick lead V1 or V2, make sure you don't pick them both and add them together. And also atrial hypertrophy, which is also very busy. I remember one of the students in a session saying that the right and left atrium, that right reaches, and that means a P wave that's 3 boxes tall. And she also mentioned that it helped her to remember by saying left is long, and that's 3 boxes long or 3 boxes wide. And let's take a look at some examples, and perhaps this will become. The slide is titled left ventricular hypertrophy. And if you take a look at the criteria, again picking the largest S wave in V1 or V2, I would pick V2. And the largest R wave in V5 or V6, I would pick V5. You can add those two together and clearly they're greater than 35. In addition, this might be a good time to point out something called the strain pattern of hypertrophy. And the strain pattern means that the T wave is asymmetrically inverted. It's not quite perfectly inverted. It's a little bit more downward and then it will quickly slope up. Later we'll talk about ischemia, which also causes T wave inversion, and how do you tell the difference? Well, before I would label it as a strain pattern, of course you first have to have hypertrophy, so make sure that you have hypertrophy, and then make sure that the strain pattern is in the proper leads. So in this example, left ventricular hypertrophy, you see the T wave inversions in leads V5 and V6. And again, looking at the EKG tech as they hook the patient up, leads V5 and V6 are on the left side of the heart, so this would be left ventricular hypertrophy. And you'll also notice that it does pull the axis leftward. Atrial hypertrophy is somewhat harder to look at, but basically for left atrial hypertrophy we look in lead 2, which may be somewhat difficult, but it is 3 small boxes long. And also if you look in lead V1, which is the second criteria, the P wave is mainly negative. The terminology, an increase in the terminal negative deflection, is always rather interesting. Nobody knows what it means, including me. But I think what the authors mean there, and you'll see this in several books, is that the T wave is mainly negative. And it makes sense. If you have left ventricular hypertrophy, you're probably going to have left atrial hypertrophy. And a good example of this patient may be someone who has long-standing hypertension, for instance. And again, if we look at the next one, which is right ventricular hypertrophy, here, if you look at V1, you'll see that the R wave is taller than the S wave, and that should really never happen in a normal tracing. And as you go from V1 to V6, your R wave actually gets smaller, which is the exact opposite of what it should be in the normal adults. So this certainly looks like it could be right ventricular hypertrophy. And in addition, right atrial hypertrophy, again in lead 2, the right reaches, it's somewhat difficult to see exactly how many boxes high the P wave is, but I think everyone would agree that the P waves are abnormally large when you look at the corresponding QRSs. They look almost as large or larger. And then the second criteria is mainly that the P wave is positive in lead V1, and again this initial positive deflection terminology.
Oh, great. Very helpful. The last section in this podcast will be on